Welcome to this explainer. Hearing a skin cancer diagnosis is without a doubt a profound moment. But as you'll see today, the name of the cancer, well, that's really just the starting point. Today we're diving into the evidence, which is current as of July 11, 2026, to see exactly how different features completely change a clinical plan. Now, I want to set a calm, objective tone right out of the gate here. This is an evidence-based general education explainer, not individual medical advice. We're here to look at the data and understand how care teams actually navigate these big decisions. Okay, let's dive into this. First, we'll talk about how risk is a stack. Then, what risk labels actually mean, followed by real outcomes in Class CSCC. Next, we'll cover surgery and matching the method, look at non-surgical options and observation, and finally, wrap up with the best questions to ask your doctor. Section 1. Risk is a stack. So let's introduce a core concept that might just shift everything you assume about a skin's cancer diagnosis. The name of the cancer literally does not hand you the whole treatment plan. Why? Because risk is not one single label. It's actually a stack of information. Two patients could get the exact same diagnosis and require completely different care. It's like a giant puzzle where tumor type, location, borders, pathology, size, depth, recurrence, nerve involvement, immune status, prior radiation, patient health, and the patient's own goals all work together. When you stack these factors up, they fundamentally change the urgency and the treatment plan. Moving on to Section 2. What risk labels mean. We hear terms like low risk and high risk thrown around all the time, right? But what do they actually mean in the clinic? Well, lower risk does not mean harmless. It usually just means a simpler treatment is more likely to be sufficient. On the flip side, higher risk does not mean hopeless. A high-risk label simply tells the care team how much margin control, staging, follow-up, or multidisciplinary planning might be needed. It dictates the intensity of the approach. It's not a guarantee of the final outcome. To really ground this, let's look at a couple of quick examples across basal cell carcinoma, or BCC, and cutaneous squamous cell carcinoma, or CSCC. And don't worry, we're not turning this into a medical textbook. For BCC, a small, sharply defined tumor on the trunk, that might be treated very differently from a recurrent, infiltrative tumor on the nose, which needs much more delicate tissue conservation. For CSCC, a thin, well-defined tumor on a low-risk site is an entirely different ballgame than a deep tumor in an immunosuppressed patient. Same diagnosis, vastly different care. Section 3. Real outcomes in CSC. So how do these risk labels actually play out over time? We're going to look specifically at a 5-year horizon for cutaneous squamous cell carcinoma, looking at low-risk versus very high-risk categories. Now, this data comes from a retrospective observational cohort of 10,196 patients. Let me be absolutely clear, we cannot generalize these numbers to every skin cancer. But look at the sheer difference here. The adjusted 5-year local recurrence was 0.8% for low-risk tumors, compared to 9.4% for very high-risk tumors. For disease-specific death, it was 0.1% for low risk, compared to 10.5% for very high risk. To put that into perspective, this is exactly why risk stratification is taken so seriously. And this brilliantly illustrates the impact of surgical choices in that exact same retrospective observational cohort. For those high-stakes CSSC tumors, using Mohs or another peripheral and deep end-face margin assessment, often abbreviated as PDMA, was associated with lower adjusted subhazards of local recurrence and disease-specific death compared to standard wide local excision. Notice our wording here. We're saying the method was associated with better outcomes. Because this is observational data, we carefully say associated with, rather than saying it caused or proved the difference or that it guaranteed a cure. Section 4, Surgery, Matching the Method. Now that we understand the risk stack we built earlier, how does it actually inform the surgical approach? The goal here is matching the method to the specific tumor. Mohs, or another complete mapped margin method, is often strongest when the tumor is high risk, recurrent, aggressive, poorly defined, or sitting on tissue-sensitive anatomy where you really can't afford to lose unnecessary normal skin. On the other hand, standard excision can be absolutely excellent for many primary, well-defined lower-risk tumors. The big takeaway here? A genuinely low-risk tumor shouldn't automatically get the most complex treatment. The treatment must match the risk. If your tumor does fall into a higher risk category, remember that it usually calls for prompt planning, not panic. You definitely shouldn't assume the cancer has spread, but you also shouldn't just let a high-risk result sit in an unread inbox. Features that should accelerate communication with your treating team include rapid growth, new pain or numbness, fixation to deeper tissue, enlarged nearby lymph nodes, recurrence after prior treatment, immune suppression, or pathology showing high-risk features. Section 5. Non-surgical options and observation. Surgery is a fantastic primary tool, but it's not the only tool in the box. Selected non-surgical treatments can fit selected superficial or low-risk tumors safely and effectively. This could be EDNC, which is electrification and curettage, or targeted topical therapies for certain superficial tumors. Radiation might also be on the table when surgery just isn't a good fit for the patient's specific situation. Now, what's really interesting about this slide is that there's also data on observation, the choice to just watch the tumor. But I have to caution you right away. Wait and see is absolutely not a general skin cancer strategy. Let's look exactly at who this data applies to so we don't get our wires crossed. To make sure this isn't misinterpreted as a general recommendation for the public, I'm going to read the full scope statement of this clinical observation data word for word. In a selected study of 280 BCCs in 89 predominantly elderly patients, measurable growth data were available for 124 tumors. 58 of those 124, or 46.8%, showed no measurable increase during follow-up. Patients were selected mainly because of frailty, comorbidity, or limited life expectancy. So, observation is unusual, but it may fit carefully selected frail patients when the burden of treatment outweighs the benefit. Section 6. Questions for your doctor. The entire point of understanding this whole risk stack concept is to empower you to have a really productive conversation with your healthcare team. I want to leave you with this final thought. The best thing you can do is turn your specific risk stack into an actionable, individualized plan. So ask your doctor this exact question. Which features make this tumor lower risk or higher risk? And how do those features change treatment and follow-up? By asking that, you make sure your care perfectly matches your unique stack of factors. Thanks for joining me to explore this explainer today, and keep asking great questions.